Welcome to the deep dive. Today, we're getting into something that's really transforming healthcare, health informatics.
Hmm.
And we're looking at it, well, specifically from the nurse's point of view, using excerpts from Fast Facts and Health Informatics for Nurses.
Yeah, that's a great source. It's really packed with info on how tech and data are changing things. Not just computers, but how data gets used, how it supports decisions.
And the human side of it all. Okay?
Exactly, the actual experience.
So our mission today is, cut through the jargon. What is health informatics? Why is it so crucial now for nurses?
And how does it all connect? Patient care, data, tech, and the people involved.
Precisely.
Okay, so maybe start with the terms. IT, HIT, informatics.
Yeah.
It can get a bit jumbled.
Good idea. The source breaks it down well. Information technology, IT, that's the big umbrella, right?
Yeah.
Systems for storing, retrieving, distributing info, using computers. It's everywhere.
Right, and health information technology, HIT, that's just IT specifically in healthcare.
Like EHRs, EMRs.
Yep. Electronic health records, medical records, even public health stuff.
The informatics itself. That's the science, the study of IT and how it all works.
Which brings us to health informatics, the science and study of HIT. But, and this is key, always aimed at improving patient care.
It's not tech for tech's sake.
Never. It's about better care, better outcomes.
And the source is pretty clear. Going digital isn't really optional anymore if we want those better outcomes.
Absolutely essential. And one really direct way informatics helps nurses is with evidence-based practice, EBP.
Ah, yeah. Finding the best evidence quickly.
Exactly. Tools let nurses search peer-reviewed literature fast, using filters, Boolean terms, getting that evidence to the bedside.
Huge. And then managing it all with things like RefWorks or EndNote.
Right, which is why nurse informaticists and educators are so vital. They keep everyone current, help them actually use these tools effectively for EBP.
Making sure the knowledge gets applied. And here's a quick fast fact bite on that. Peer-reviewed articles, they're read and approved by experts before publication. That's what makes them credible evidence.
Good point. Okay, so moving from definitions, the scale of this digital revolution, it's huge. McKinsey warned about big data years back.
And now you see it everywhere. Nurses with iPads, mobile devices, paper charts are disappearing.
Yeah, and they're using tech for everything: admin, unit management, staff training, patient care, apps for all of it.
Plus, all the online resources, clinical guidelines are just clicks away from professional bodies, government, hospitals.
Right at the point of care or for planning.
And all this digital activity, it's creating this massive wave of data, big data.
EHRs are a huge part, yeah. But also pharmacies, wearables, smartphones.
Even internet searches, store loyalty cards. AI puts it all together somehow.
And it's a massive market. Healthcare analytics, driven by this data, projected at, what, $54 billion worldwide by 2025.
Wow. That's driven by the push for more patient-centered precision care, right? Which needs that deep data dive.
Which is where AI and predictive models come in. Training algorithms on past data to predict things, like how a patient might respond to pneumonia treatment.
Because computers can crunch way more variables than we can, potentially more accurate predictions.
Essentially, yeah.
The scale is just hard to grasp. Some fast fact bites. Over 90% of all data ever created happened in the last 2 years.
Mind-blowing.
Data created every second, and yet less than 0.5% gets analyzed.
So much potential just sitting there.
And back in 2020, over 50 billion smart devices were sharing data. Imagine now.
It's staggering.
Yeah.
But, volume isn't everything. You have to understand it. That's where the DIKW framework helps. Data, information, knowledge, wisdom.
Right. Fundamental for nurses. So data is just the raw stuff. Numbers, observations.
Yeah. Age, BP, heart rate, maybe mood. By itself, not much meaning. Like a BP of 330/80. Okay, so what?
Information is when you put data together and interpret it. The source uses Harold's MUWS score example.
Perfect example. Individual vital signs. The data get fed into a system, interpreted, and boom, a score. That's information. It tells you something changed.
Okay. Then knowledge. Combining the info with experience, education, actually understanding the situation.
Right. The nurse sees Harold's score, looks at his other signs, his history, and understands why things are changing. They integrate it all.
Which leads to wisdom. Applying that knowledge ethically, appropriately, making the right call at the right time.
Using experience, evidence, the patient's context. It's that expert gut feeling sometimes.
You can really see the link to Benner's stages here, can't you? Novice to expert.
Absolutely. A novice might just react to the MUWS score, the information. An expert uses wisdom. They see subtle data points before the score tanks. based on experience.
It's that journey from raw numbers to wise action.
Exactly. And the data itself comes in different flavors, which matters. Structured versus unstructured.
Structured is neat and tidy. Defined fields, drop-downs.
Yeah. BP has a number field, units field, easy for computers to read, trend, report on.
Unstructured is the free-for-all. Free text notes, dictated summaries.
Pretty much handwritten stuff, images. Much harder for a computer to analyze or find trends across different entries or people.
And that's a problem, right? If everyone describes the same thing differently in free text.
Huge problem for sharing data, which brings us neatly to interoperability.
The big one. Getting different systems to actually talk to each other and understand each other.
Yeah. The hospital EHR, the lab system, the specialist system.
Yeah.
They need to exchange data and be able to use it.
But often they don't. Different vendors, different versions, like different dialects.
Or different languages entirely sometimes. It's complex. The source says some feel progress moves like tectonic plates.
Huh. Tells you something.
The ONC Office of the National Coordinator for Health IT, they're the federal folks pushing this forward.
And the 21st Century Cures Act from 2016 was a big push, wasn't it? Demanding secure exchange without special effort.
Right. That led to things like TEFCA, the Trusted Exchange Framework, and Common Agreement, aiming for a national network.
And the USCDI, the U.S. Core Data for Interoperability. That's key.
It specifies what data elements have to be shared for it to count as interoperable exchange. It builds on older standards and keeps evolving.
Think about Mrs. Betty Martin in the source example. Chemo in Ohio needs care in Florida.
Before EHRs and interoperability efforts, getting her records would be a nightmare. Delays, incomplete info.
But now, ideally, the Florida Center can access her history, notes, labs electronically, much smoother, safer continuity of care.
Plus, she can use her patient portal, that's a type of PHR, to message her team, get refills.
Right, so that seamless connection is the goal, making a real difference for patients moving between providers.
Definitely.
Okay, you mentioned EHRs, EMRs, PHRs. Let's quickly nail down the differences.
Okay, EMR, electronic medical record. Think digital chart, but just for one specific place. One clinic, one hospital. Tracks data over time there.
Got it. Single setting.
EHR, electronic health record. That's designed to be broader.
Yeah.
Data from multiple providers, multiple settings. Follows the patient across the care continuum.
Between hospitals, labs, states, potentially.
If the interoperability is there, yes. And then PHR, personal health record. That's the patient's own record, managed by them.
Could be paper, could be an app, meds, diagnoses, history, whatever the track.
Yeah. Could be linked to a health system, like Mrs. Martin's portal, or from an insurer, or a standalone app. Patient-controlled.
And that linked, that ability to share data outside one system, fast fact bite, that's what interoperability enables. True continuity.
And the HITech Act back in 2009 really kicked this adoption into high gear, promoting meaningful use of HIT. Bipartisan support, actually.
Putting in an EHR or EMR, that's a huge project for a hospital, right?
A massive cost, planning, workflow analysis, training. It's a multi-year effort. Phase 1 alone involves analysis, planning, investment, initial training. Often starts with RFIs to vendors.
Complex stuff, and all this runs on the underlying tech architecture.
Yep. Starts with computing systems, hardware, the physical bits, chips, motherboards, servers.
And software, the instructions, operating systems, programming tools, and general use programs like Office, browsers.
And that caution note from the source is important here about general use software.
Right, not usually regulated like medical software. It can hide malicious code.
Exactly. Be careful what you download or install, especially on work machines.
These systems connect via computer networks, LANs for local areas.
Like one building. And WANs for wider areas.
Like a big hospital system across a region, the internet being the ultimate public WAN.
And increasingly, healthcare uses cloud computing, delivering services over the internet.
Healthcare cloud, HSaaS, HPaaS, HIS.
Right. Software as a service, SaaS, is like using a web-based EHR hosted by the vendor. Platform as a service, PaaS, is like renting online tools to build your own stuff. Infrastructure as a service, AJONI is renting virtual servers and storage.
Good clarification. Different models, different implications for control, security, cost.
Yeah, and the source mentions blockchain is promising too, that decentralized ledger.
Very resistant to tampering. Good for data integrity. Micropayments.
Potential there, yeah. But with all this data flying around, security and privacy are paramount.
Absolutely critical. Network security is the baseline.
And honestly, so many threats can be avoided just by users following basic procedures.
Like with wireless networks, secured versus unsecured public Wi-Fi.
Big difference. Avoid sending any sensitive data over unsecured Wi-Fi unless you're using a VPN.
A virtual private network
Correct.
creates a secure tunnel.
And the source lists those essential security practices everyone should follow. We should probably list those fast fact bites.
Good idea. Fast fact bites on standard IT security. Never send unencrypted patient data over an unsecured network.
Always log out when you leave a computer.
Report suspicious activity immediately.
Don't download games or general programs onto work networks.
Never open unexpected email attachments or links.
Avoid risky websites on work computers.
Stop and call IT if you see weird prompts asking to install things.
Don't click pop-up ad links or buttons.
And never plug in unknown USB drives.
Basics, but so important, because malware viruses, spyware gets in easily through those routes.
And the source says common breach causes are things like password sharing.
Which it says there's no excuse for.
And using personal devices inappropriately.
All covered by regulations like HIPAA and high-tech, which have strict privacy and security rules.
Okay, so beyond the EHR, what other tech is big in practice?
Telehealth is huge. Using tech for remote care, education, public health. Lots of investment going into the infrastructure for it.
And telenursing is the nursing piece of that. Remote monitoring, consults.
Yeah, helps with workforce shortages too, especially with things like the enhanced nurse licensure compact, letting nurses practice across state lines more easily.
Then there are wearables, sensors worn on the body.
Measuring a heart rate, glucose, steps. Some are even implantable or ingestible, needing FDA approval.
But the source points out that most consumer wearables don't need rigorous testing.
That's the tricky part. Lack of strong evidence. Are they reliable? Safe? Is the data valid for clinical use? Who owns the data? Is it secure?
Lots of questions before you can really rely on them clinically.
Definitely. There are guidelines for using them in research, but everyday clinical use is still evolving.
Okay, shifting back inside the systems. Decision support tools. Becoming standard.
Yeah. Simple things like reminders or flagged results, more complex flowcharts.
And AI taking it further. Machine learning algorithms, spotting patterns, predicting complications.
Using all sorts of data vitals, labs, genetics, demographics. Developed rapidly to support quality and precision medicine.
But when software starts guiding medical decisions, that needs oversight, right? Software as a medical device, SAMD.
Exactly. The FDA regulates that. There are draft guidelines, risk categories based on intended use and patient condition severity.
Critical, serious, routine.
Right. Higher risk means more evidence needed before it hits the market, making sure it's safe and effective if it's influencing care.
Makes sense. Regulation matches the potential risk.
And speaking of impact, we absolutely have to talk about the human factor. User experience, UX.
So important. Not just clinician frustration, but actual quality and safety implications. The source says input from everyone is needed for good design.
Totally. Hospitals spend fortunes on these systems. If the UX is bad, it undermines everything. Poor outcomes are a real risk.
And we've all heard stories about rough EMR implementations, cost, training issues.
The Dr. Benjamin example in the source is powerful. The cardiologist who was lost after conversion, couldn't find notes, place orders, felt training failed him, especially with his dyslexia.
Oof, yeah, that hits home. It raises so many questions. How do you train better? Support people after go live? Why does staff satisfaction matter so much?
Because it directly impacts how well they use the system, which impacts care. How do you help struggling staff become efficient? What about different learning needs?
It shows technology isn't just wires and code, it's about the people using it. Satisfaction is key to effective, safe use.
Absolutely. Which brings us finally to the foundation underneath all of this. Ethics.
Right. Health Informatics is full of ethical considerations.
The source uses those core bioethics principles. Justice, fair distribution of care and resources. Beneficence, doing good.
Non-maleficence, doing no harm. Accountability, taking responsibility. Fidelity, keeping promises.
Autonomy, patience, self-determination, especially with their data. And veracity, being truthful.
And applying those to EHRs, AI, data privacy. It's complex. Constant ethical navigation is needed.
For sure.
Okay, wow. Let's try and recap this deep dive. We went from basic definitions, IT, HIT, informatics, and that DIKW framework, data, to wisdom.
We tackled the big challenge of interoperability, getting systems to talk, driven by laws like the Cures Act and standards like US CDI. Saw how vital that is for patients like Mrs. Martin.
Looked under the hood at the tech architecture, hardware, software, networks, cloud, even blockchain possibilities, and hammered home the need for robust security and privacy, following HIPAA and HITech.
Yeah, and those crucial security practices. We also touched on tech, extending care, telehealth, telenursing, and the potential, plus the current questions. around wearables.
Explored decision support, AI, and how software as a medical device is regulated based on risk, ensuring safety.
And spend important time on the human element. User experience isn't optional, it's critical for safety and quality. Staff satisfaction matters. Dr. Benjamin's story really highlights that.
And wrapped it all in those fundamental ethical principles: justice, autonomy, beneficence, non-maleficence, guiding how we use all this power responsibly.
It really shows that health informatics isn't just for the IT folks. It's core to nursing practice now. Everyone needs to be engaged.
So as we finish, here's something to think about. Building on that data explosion we discussed, with all this health data pouring in from EHRs, wearables, genetics, public health, you name it, and knowing less than 0.5% is actually analyzed. What does that huge untapped ocean of information really mean for the future of healthcare? And maybe more importantly, whose job is it to figure out how we unlock that potential safely, ethically, and effectively for every single patient?
That's the multi-billion-dollar question, isn't it? A massive opportunity and a profound responsibility.